Okay. So with rheumatoid arthritis, when you say rheuma, rheum, rheum means flow. When something is flowing, okay? Flow. Like what? Blood. Okay, blood flows, isn't it? So blood flows, rheum. And toid is like something that resembles like. So, and arthritis. Art means bone. Itis means inflammation. So rheumatoid arthritis, you are looking at flow. Okay, that looks like rheumatism. Okay, but this one, it's having effects on the bone, the arts, itis, and inflammation. Okay, so just get this basis and you will understand it so easily. So with this one, we are saying that it's an autoimmune condition. Autoimmune means that there should be an antigen which will stimulate the immune system to start fighting against the body. All right. And this one is not like we are only looking at the bone, but it's because the bone is also involved. As I told you, rheum means what? Flow. Blood. It flows to every organ. It flows to every part of the body, isn't it? So rheum means flows. So it means that this condition is affecting every part of the body because it's flowing to all parts of the body. All right. So we are just attaching the arthritis in a sense that it also causes an inflammation to the bones or to the joints. You understand, please? So when we say rheumatoid arthritis, we are just looking at an autoimmune condition, and it's a chronic condition. Once it's an autoimmune, it becomes a chronic condition that we have. And we are saying that it's a systemic because the blood flows to every part of the system. So it's a systemic inflammation, systemic chronic autoimmune disease, and its main features are what? There's an inflammation of the synovial joints and then connective tissues. Okay. So if there's an activation of the immune system, it causes an inflammation in the synovial joints. Okay, that is synovitis. And once the synovial membrane inflates, okay, eventually it will form what called panels. Panels is just a structure that eats into the joints. Once the synovial membrane inflames, okay, and it becomes necrotic or it becomes damaged, it will eat into the bones. All right. And eventually there's a cartilage destruction. All right. So let me show you the anatomy of it and you see everything. Okay. A minute, please. Okay. So I'm showing you something. Have you seen this one? Let me show you this one. Okay. So we have a bone here. All right. The bone is in the middle. And with this one, we call it what? Synovial membrane, which contains the what? The synovial fluid. Okay. The fluid is this one. All right. It's here. That's the fluid. And this one, this structure is the membrane, synovial membrane. Okay. And this one is articular cartilage. This one helps with the bone to slide against each other, okay, without having an injury. That's the articular what? Cartilage. All right. That's the one that is green. Okay. Articular cartilage. And we have the synovial fluid, which is in the what? The synovial membrane. Okay. And we have the joint. So the whole thing is the joint. So when you say pumps, once there's an inflammation of the synovial membrane, okay, synovial membrane, you see, it will the structure there will get damaged, and there's a formation of some structure which goes that almost occupying the joint. All right, that is the what? The panels that we are talking about. All right, so in rheumatoid arthritis, okay, we are looking at a chronic inflammation systemic, but this one, it also affects what? The bones, the joint, and particularly the synovial joint and the connective tissues. Okay, so when we have this abnormal growth, okay, abnormal growth, all right, or granulation tissues that eats into the joints, occupying the space of the synovial fluid. That is what we call humps. Because with this one, there's going to be an inflammation of the synovial membrane, affecting the fluid. All right, and there's going to be formation of these abnormal growth, okay, that eats into the joints. Do you understand? So once it happens like that, it will affect the bone movement, the joint, the movement of the joints. Okay, so there's synovitis, that is inflammation of the synovial membrane. Okay, the whole membrane is inflamed, and eventually it will lead to a granulation. Okay, abnormal growth. All right, which goes into the joints, occupying the space of the fluid. Okay, and eventually the cartilages that we saw get destroyed. Okay, it means that the cartilage, it helps with the bone friction. It prevents excessive friction. Okay, so once the cartilages are damaged or destroyed, then the structures there, the structures that we saw will start eroding, going away. Okay, including the bone itself. Okay, the bone erosion. All right, and eventually the joint is deformed. The patient can't use the joint again. And that is not only the joint that is going to affect. Because I told you, blue means flow. And blood, it flows to every part of the body. So it means that it's going to affect every part of the body. Okay, it will affect the brain, the eye, the kidneys, the skin, the liver, every part of the body. So when it's mostly affects the joint of the hands in the feet. Okay. And we have what we call the metacarpal, and then the metacarpal, that is the metacarpal phalangeal and the proximal interphalangeal joints. Okay, that's where it affects. And the wrist and also the elbows. So this one, arthritis, we are looking at the joints and the shoulders and the knees, knee joints, the hips and the ankles and the jaw. Okay. That is what is actually happening. Okay. You said you can't hear me. Hello. Is it okay now?
Say, I can't hear you because the volume is too low. I don't know if it's on my side or on your side.
Uh, is it okay now? I hope it's okay.
But front,
Hello.
I think maybe it's their end.
But it's okay, right?
Yeah, it's okay.
Okay. So that is all that's happening. So mostly, I told you that it affects the joint and the small joints. Okay, but it can affect every part of the body, every joint of the body. Okay, so with the small joints, the hands on the hands and the feet. Okay, that's mostly what they affect, but they can affect every bone, every part of the bone. Okay, so your hip, your knees, your ankle, your wrist, elbows, okay, shoulders, the jaw, wherever we have a joint. Okay, this can affect. Okay, and this one, we are saying that it has a symmetrical distribution. Real, which is a flows to every part of the body. Okay, so it means that if it's affecting the middle finger of the right hand, at the same time, it affects the middle finger of the left hand. So it has a symmetrical distribution because blood flows to every part of the body symmetrically. Okay, so that is what you should know. And this one, physical stress or emotional stress or fatigue can cause flare-ups. When I say flare-ups, you are looking at exacerbation. Okay, when you are emotionally stressed or physical stress or fatigue can increase the pain, can increase the symptoms. All right, so it's like when physically you do a lot of work, become stressed, become tired, because every part of the body is being used. That's rheumatoid. Every part of the body is affected. So physical stress affects the whole body. Emotional stress, fatigue can cause flare-ups. Okay, and we have vasculitis because it affects the vessels as well. Okay, and when the vessels are inflamed, okay, it will impede blood flow. It will have effects on the organ. That's where the blood vessel is supplying. All right, so it has a systemic effect. Okay, and it causes the failure of the organ because of what? Ischemia. Because when the vessels are inflamed or edematous, they will impede blood flow. Blood flow to that particular organ will be impeded and eventually cause what? Ischemia. So it can cause inflammation of the vessels as well. Because I told you that this one is an eye, it's inflammation. So inflammation can occur every part of the body. All right. And rheumatoid nodules, that's firm, non-cancerous lumps. Okay, because it has to do with flow of blood, flow. Going to have nodules, and that is found in the elbows and in the hand. Okay, so let me show you how this one also is. Okay, Yes, I hope you can see it. That is rheumatoid noodles. Okay, there's inflammation at the joint. Inflammation of the joint. Okay, so you can see this part that's swollen here. There's another here and here as well. All right, that is the rheumatoid noodles that affect the joints. Okay. All right. So we are saying that there is rheumatoid noodles. That's very, very fair, but it's not cancerous. It's not a cancer. It's non-cancerous. And it's a lump. That's a raised swelling that you can see there. Okay. And that is found in the elbows, in the hands, and other places where there'll be an inflammation. Okay. How do we see that this patient is manifesting rheumatoid arthritis or showing signs of rheumatoid arthritis? We say that it is symmetrical because blood flows everywhere. So you see it here on the right hand, at the same time, you see it on the other side, left hand. Okay. So it's a bilateral inflammation or what? Polyarthritis. So as you saw on the hand, there's multiples of what? Inflammation. Okay. So bilateral means that one hand and the other hand are all affected. It's not only one hand that we see the inflammation there. Okay. Both hands, bilateral. Okay. And pain becomes worse with what? Prolonged rest. If you're having blood flow, if you lie down on one side for a long time, the blood flow, the blood flows reduces. Okay. And after a long time, you can see that walking becomes very difficult. Okay. It's like our normal lifestyle. If you lie down or sit at one place for a long time, there's going to be obviously the speed of blood flow decreases. Okay, so after waking up, you can see that every part of the body pains. Okay, so this one has to do with what? Pain, which becomes worse after what? Prolonged rest. But once you engage in activity, pain will not go down. Okay, but if it has to do with normal movement, when it comes to movement, moving the joints and those stuff, it becomes painful. But if, let's say, after waking up, you start doing some activity, you see that the pain starts going down. Normal activity. I mean normal activity. That's where you see the pain becomes better. But if you stay down, you stay still or remain still for a long time, once you start walking, see that the pain intensifies. All right. And morning stiffness lasting longer than 30 minutes or sometimes even 1 hour. Because it's a flow of blood. And once you lie down, okay, you sleep. After waking up, you can see that you look very tired. And once you know that blood is flowing to every part of the system, means that it takes a longer time, okay, for stiffness to go down. So it doesn't only come with pain, it comes with what? Stiffness. Because if you stay at one place for a long time, that joint becomes what? Stiff. So we have morning stiffness and pain. But this type of stiffness lasts longer because it's a flow of blood. Okay, so you need to do a lot of exercises or you need to do a lot of activities before the pain goes down or the stiffness goes down. Okay, and there's limited motion can happen at any age. Know that blood flow doesn't depend on age. Unlike osteoarthritis, which can affect only the aged, this one, blood flow, it has no respect for age, isn't it? For young adults, there's blood, we have blood, okay? It flows everywhere. So it's like that. So with rheumatoid arthritis, young age can even get it, okay? Young adults, they can get it, all right? So unlike osteoarthritis, which happens to the aged, this one, once you know that it's a flow, and the young and the aged, they all have blood flow. So it will have effects even at younger age, okay? And obviously, because of inflammation, there's going to be signs of inflammation at that local area. So we see heat, swelling, and tenderness. And because it's a systemic, okay, we are going to have low-grade fever, okay, spongy, soft feeling in the joint. This one is soft feeling, okay, muscle atrophy. Because when the place or the joint becomes stiff, you are not using, you don't want to use it because of pain. Because when you move it vigorously, it becomes very painful. So you don't want to do that. And once it happens like that, you see that the muscle start wasting. Okay, muscle or atrophy and tendon destruction. Because you are not moving the joint. Okay, you're not moving the joint and contractures can form. Do you get it? So that is what is happening. And stabilization, that's incomplete or separation of the joint. Because as you saw with the first image, okay, you can see that the panels is eating into the joint. And eventually the cartilages and then the synovial fluid there, the membrane, they are all damaged. And the bone will slip past the other bone. That is what we call stabilization. Okay. And we have what we call swan neck. Okay. And the bottomere contractures. Let me show you how this one looks like. I hope you know a bird called swan. Okay. Can you see this, please? Can you see this, please?
Yes, please.
All right. You can see that. So this one, what joint is that? So this one is the proximal joint, okay, of the hand, okay? And this one is what? The distal, far away, okay, from the body, okay? So distal. And this one is what? The proximal, okay? So you can see that, okay, this one is a bit better. So the distal, the phalangeal flexion, you can see that this one is flexed, okay? And the middle one, the proximal, okay, is what? Hyper extended. It's like a neck of a swan. That's what they call swan neck deformity. Do you understand? So it's like an animal. See the animal, they are around getting to the head. It's like this. Okay? That is what we call swan neck deformity in rheumatoid arthritis. Do you understand the point? Swan neck. In swan neck, know that the proximal, we have proximal and the distal joint. We are looking at the proximal and the distal joint of the hand. Okay. And know that the distal is the far away joint. distal, distance. Okay, and proximal means that closer to the body. So distal is what? Placed. And the proximal is what? Extended. It goes deep inside. Okay, and this one is placed. Okay, the distal is what? Placed. And the proximal is hyperextended. That is what we call swan neck deformity. It happens in what? In rheumatoid arthritis. And the other one, the bottom deformity, is the opposite. You have the distal having what? Extension, and the proximal what? Placed. Okay. Let me show you. Okay. Have you seen this? See, this one is extended. Okay, the distal one is extended. Okay, dips inside, and then the proximal, the PIP, the proximal, the pharyngeal joint. Okay, is what? Placed. So that one is opposite of what? The swan neck. So swan neck, we have the distal one what? Placed, and the proximal extended. Is that okay, please? So that is the bottom-ear what? Deformity. Bottom-ear deformity, and the swan neck deformity in rheumatoid arthritis. Is that okay, please?
Yes, sir.
Okay. All right. So that is swan neck. The middle joint bends back too far. The middle joint. Okay. Top joint bends downwards. All right. And the bottom ear is the middle joint bends inward, and the outer joint what bends backwards. Okay. That is what we have anal deviation. Okay, that also happens in this. And systemic manifestation, because it's a blood flow, goes to every part of the body, systemic. So we are going to have what? Fatigue. We are going to have anorexia. We are going to have weight loss, anemia. Can affect every part of the body. It can affect, I told you, it can affect the lungs, it can affect the eyes, it can affect the brain, it can affect the heart, every part. Okay, so we can have cataracts. Okay, we can have vision problems. We can have pleurisy in the lungs. Okay, you can have pleural effusion. All right, inflammation, because it's inflammation. So there's going to be collection of fluid in the pleural space. Okay, pericarditis, inflammation of the pericardium. Okay, rheumatoid nodules that as you saw on the hand. All right, so these are extra manifestation. Extra articulate means away from, apart from the joint. Okay, and we have systemic manifestation because it affects the whole system. All right. So how are you going to diagnose? We have arthroscopy. Okay, with this one, they are going to aspirate with the help of the scopy. All right, they are going to aspirate what? The synovial fluid for investigation. Okay, and what are they going to see? You can see that the synovial fluid is what? Cloudy. Okay, with increased WBC because there's inflammation ongoing. Okay, inflammation ongoing. And we saw that the synovial fluid, the membrane are all damaged. So that place becomes cloudy with increased WBC at the joint. So they will do synovial fluid analysis by aspirating with the help of what? Arthroscopy. Okay. X-ray can also show that there's a damage to the joint. Okay. To the synovial membrane, the joint, and they can even see the panels formation. Okay. Positive rheumatoid factor. That is the antibody that we are talking about. Because this antibody is going to initiate the whole cascade. Okay, so rheumatoid factor, once you see that they do this and see rheumatoid factor, and if there's presence of rheumatoid factor, it's a positive indication that there are rheumatoid arthritis. Okay. Increase what? ESR. Okay, and CRP as well. And these indicate what? Inflammation. I hope you get it.
Was Frank, please, I have a question.
Yes, please.
Does panus forms at the joints, at the junction of the synovial tissue after the rheumatoid arthritis has taken place, or is what causes it?
No, it's once, because it's a what's the name? It follows in order. First of all, it needs to be, this one is the environmental and genetic what's the name? Genetic connection that stimulates the immune system. Okay, to have the rheumatoid factor, which will cause inflammation in the vessels as well as the synovial membrane. Okay, and once the synovial membrane and the fluid is damaged, that's where we see other granulation tissues, other abnormal tissue forming.
Okay.
Okay, forming inside the joints.
The joints.
Okay, and eventually cause what? Deformity.
Okay.
You understand?
So I understand. Then now about the blood carrying it from system to system, like the ischemia, everything. I've not really understood that movement. Sorry.
Because with this one, I told you that it's a systemic condition, rheumatoid arthritis. And once you are looking at flow, and once it affects every part of the body, so it can affect the vessels. Okay. Where we had the inflammation of the vessels. And if we have inflammation of the vessels, it means that where the vessel is supplying, what will happen to it?
Ischemia. Okay.
You get it? If it's about the bone in the vertebra, okay, or the bone in the hand, sometimes if it's about the bone in the vertebra and there's swelling there around, if there's a nerve, okay, a nerve that's passing through the bone, what will happen to it? It causes compression to the nerve.
The nerve.
You understand?
Yes, sir.
That is what we are looking at. It's a systemic condition. Because
thank you.
We are looking at blue. Blue, as I told you, is what? Flow. So once blood is flowing to every part of the body, it means that this affects the system and is symmetrical. It means that once it affects the right hand, at the same time it's affecting the left hand. Unlike osteoarthritis, where you see only left hand, there's inflammation of the joint of the right hand or whatever. But this one, it's a system flow affecting every part of the body. You understand, please? So you can see that the inflammatory distance, that's erythrocyte segmentation rate and C-reactive protein, they are all going to go up because it tells you that there's inflammation ongoing. Okay, and once we are having inflammation there at the joint, at the vessels, at every place of every part of the body, we are going to have an increase in what? In the WBC, especially if you take fluid, you aspirate fluid from the joint. You can see that it's cloudy because the synovial fluid is clear. But if the membrane is damaged, causing granulation tissues or abnormal tissue growth, do you think that the fluid will be cloudy? Sorry, will be clear? No. I hope you get it.
Yes, I
And
do.
the one thing is what? The positive rheumatoid factor that we are going to see. That's the antibody what that we are going to see. And once we see that, we can confirm that this is a rheumatoid arthritis because we've seen rheumatoid factor in the blood. You get it, please? How are you going to intervene? So just know that we are looking at joints, contractures forming because of pain, you don't want to use the joint. Okay, so our focus here is to make use of the joint. Okay, if not, there's going to be contractures, and if it's going to affect the system. So our focus is here, we are looking at the joint at large. Okay, so what are you going to do? And because it's an autoimmune, we need something that will suppress the immune system. You understand? Because the autoimmune, the immune system has been activated, causing destruction to the system, to the bones. So we need to suppress it by giving what? Methotrexate. Okay, that is disease modifying medications. All right, so once we give methotrexate, and this one is given weekly. All right, you know, methotrexate we can use in treating what? In treating what?
Cancer.
Cancer. Treatment of cancer. So once you are using methotrexate, you have to think of the bone. You have to think of the liver. You have to think of the kidney. So these three things, you have to be particular about it. So it's going to suppress the bone. So if it's going to suppress the bone, over here, we are looking at looking for signs of what? Infection as well. All right? It affects the liver, especially if it becomes concentrated in the blood, okay, in the kidney, because it's eliminated through the kidney. Okay. And with this one, we add folic acid to it because of the its effect. But mind you, when we are dealing with maternity, I hope we came across this drug, methotrexate. Do you remember? And we used to do what?
For ectopic pregnancy.
Ectopic pregnancy. Want to suppress the growth of the fetus. That is in the fallopian tube. Okay, so we give methotrexate. But over there, I told you that we don't give what? Folic acid. Because folic acid will counter the effect of what? The methotrexate. Because with ectopic, want to cause suppression of the growth of what? The fetus. So if you give folic acid, that one is going to counter its effect and cause an increase or fetal growth, which of course wouldn't achieve the aim of why you are giving the methotrexate. But over here, because of its effects on the system, it was going to suppress, as when we're dealing with ectopic, it suppresses the fetal growth. So this one also suppresses what? The bone growth and other growth in the body. So once it's going to suppress, and because of its effects, we sometimes add what? Folic acid. All right. So, but when we are dealing with ectopic, please, we never add folic acid to it. Okay. We never add folic acid to it. But if it's other, let's say you are treating cancer, you are treating other autoimmune condition with the use of methotrexate, then we have to add folic acid to it to decrease the effects of the methotrexate. Are we good? Okay. So we also have sulfasalazine, okay, and other biologics, okay, that is etanercept, okay, to suppress the immune system. Okay, so know that we give methotrexate, we give etanercept, okay, to suppress. Etanercept going to intercept with the immune activity. Okay, so it's an immune suppressor. It suppresses the immune response. And we also have corticosteroid. You know, corticosteroid also suppresses immune system, isn't it? So corticosteroid, if we give this, it's going to suppress the immune system activation and NSAIDs because of pain. Okay, but if you are giving NSAIDs, mind you need to monitor kidney function, okay, as well as what bleeding and other things, GI and things, okay, as well as if patient is having asthma. You have to be very careful when you're giving NSAIDs. You don't give in asthmatic patient, okay? If patient is bleeding, especially if you are giving NSAIDs, you have to monitor. Is there any occult blood in urine, in the stools? Assess if there's occult blood. Okay, if the stools is dark, you can see that patient is bleeding. If patient vomits and there's blood streaks, you can see that patient is bleeding. Okay, so we have to monitor for bleeding, monitor for kidney function whenever you are giving what NSAIDs. And balance rest with activity. Here we told you that it's a system. So once you sleep, blood flow decreases. The speed of blood flow decreases. And once you get up, the whole system becomes very tired. Okay, so it means that if you sleep throughout the night, you wake up. And because it's blood that is flowing, do you expect the pain or the stiffness to relieve so quickly? No. And you know that this type of stiffness that we are talking about takes longer time before it goes away. So you can see that if you are dealing with osteoarthritis, the pain, the stiffness, the morning stiffness is less than what? 30 minutes. So with this one, we more than 30 minutes or even 1 hour. Because it's a flow. That flow to the whole system. So this is a very long time for stiffness to go away. And this one, as I said, flow, the young, the old age, or the aged, they all have blood flow. So this one, it affects everyone. It affects the young. All right? Okay. So this one, we need to balance activity with rest. If you stay there, stay at one place for a long time, stiffness will come. Okay? So, and this one, we balance activity with rest, especially if there's no flare-ups. So mind you, know how to manage if there's flare-ups or if there's exacerbation, and know when how to manage if there's no flare-ups. That's the key in its management. If you understand this, every condition that has exacerbation, like asthma, has its own way of managing it if there's exacerbation and if there's no exacerbation. So with this one, because it has exacerbation, flare-ups, we need to be very careful in its management. So we are saying that if there's no exacerbation, we need to rest. That's our normal physiology. We need rest, we need activity, because that flows to every part of the body. So if there's no flare-ups, we need rest, we need to exercise. It's normal physiology. Okay, so that's what we do. But we don't do total or strict bed rest. Mind you, it's not a total or strict bed rest. You need to what? Balance it. Okay. And we need also to conserve energy. All right, need to conserve energy by prioritizing what? Tasks in the day. So daytime, because stiffness is reduced, all right, we need to do most of the activities there. But during the morning hours, there's stiffness. Okay, that one, you need to be very careful when we're engaging the patient in any activity. Okay, and sitting during task. As I told you, we need to conserve energy. Because when you move the body anyhow, that's where the pain comes. So sometimes you need to rest. So once patient is, you are helping the patient to exercise, at least you rest small, you continue the exercise, you rest, you continue the exercise. That's how you do it. Not to exercise, no. If you overstress, because I told you that physical stress and emotional stress and fatigue increase what? Pain. So this one is about rest, exercise, rest, exercise. So we have to pace activity. It's like normal physiology, like blood flowing to every part of the body. So we need the normal physiology of the body to take place. Exercise, rest, exercise, rest. Not to exercise. No. Overstressing, either emotionally, physically, can cause pain. All right. So that's what you have to do. So if patient want to conserve energy, what do? Once patient is, let's say, cooking or preparing meal, you have to what? Let the patient sit down. Because patient is using the hand to prepare. So conserve some of the energy by letting the patient sit down during task. Okay. In so doing, you are conserving energy. All right. That's what we do. So don't forget, we said we prioritize tasks where? In the day. Okay. So that's what we have to do. And schedule demanding activities during period of greatest energy. Where patient is having greatest energy, that's where we do demanding activities. All right. Not during the early mornings. But that place, pain is severe, stiffness is so high. Sleep with a small flat pillow under the head, but do not place pillows under the knees. Why? Because we are looking at blood flow. And if there's also inflammation of the vessels, okay, systemic inflammation everywhere. So if you impede blood flow, you place pillow, not even small, under the knee, you are impeding blood flow. And that one cannot worsen pain. So never place anything under knees. But at the head, just small, not large pillows. Please take note, not large pillows. Because if you do that, you are looking at systemic. Joint can be systemic, every part of the joint. Okay, it's another joint. So over here, we don't have to place large pillows under the head. If you do that, you are going to cause what we call what? Flexion contractures. I hope you remember flexion contractures when you are dealing with amputation. Do you remember? Or I've forgotten? Let me show you how it is. Don't forget, okay? All right. Just look at this. Can you see that hand? Okay. The person can't extend the hand because it has been in same position for a long time. Okay, that's what we call flexion contractures. And with rheumatoid arthritis, look at this one. Okay, because of the pain, patient can't stretch the hands, the fingers. Patient can't do that. And it'll be in that same position, dependent position, for a long time. And if it happens like that, it's going to cause contractures. So over here, your motive, your management should include what? Preventing contractures. You understand? As we saw in what's the name? Amputation. Okay. As we saw in amputation. All right. Let me. Can you see this? So you see that the joint is not straight. Now that is placed. Okay. That's in amputation where we have the flexion contractures. So that's why we learned that to prevent this, after 48 hours, we put the patient in what? In what? In what? Prone position. And when patient comes from surgery, we place sandbags side by side. All right. I hope you have not forgotten. Okay. So the same thing can happen with rheumatoid arthritis. Okay. We want to prevent, because once patient stretches the joint, pain comes. What do? Patient patient doesn't want to even stretch it. Okay. So what are we supposed to do? We have to avoid placing pillows under the knees. If you want to place pillow, it should be small, but even it shouldn't be under the knees. It should be at the head or the shoulders. If you want to, but under the knees, no, with rheumatoid arthritis, because it's a systemic inflammation of the vessels as well. So you don't want to impede blood flow. So no pillow, even not small, under the knee. All right. We have to also encourage range of motion exercise. Okay. Especially if there is what? There's no flare-ups. Okay. And want to splint joints. And splinting of joints is done especially if there's flare-ups, exacerbation. Let the joint rest and splint it so that it be in anatomical position. If not, it will lead to flexion contractures. Okay, so splinting the joint is very, very important. Okay, very, very important. And avoid provide emotional support, because if you see your hand, and especially if you are saying that it affects the young, okay, a nice lady with this condition, emotionally, patient will be disturbed. So we have to provide emotional support. Okay, well, we have to assess if there's any alteration in body image, okay, and help patient cope with this chronic condition. It's not even reversible. It's a chronic condition. Can't reverse it. So it's just about conservative management that we have to provide for the patient. So patient needs emotional support. So we have to assess for that. All right. And because of pain, as we saw in fracture, with pain, and even as we saw in nerve compression, with pain, we apply both cold and what? Warm compress. Okay. Or warm bath or paraffin bath. So we have paraffin bath, just put paraffin and then you let the patient bath. So warm bath or paraffin bath to relieve stiffness. So when you apply heat therapy or any distance, it's going to relieve stiffness. Cold will help with what? The inflammation. And then the heat therapy or the warm bath will help with what? Stiffness. As I told you, our focus is to prevent stiffness, to prevent contractures, and to reduce pain, because it's a conservative management. This one is not reversible. So how do we reduce pain? How do we reduce morning stiffness? How do we conserve energy? That's all that you need to know in rheumatoid arthritis. Okay, so the joint, how are we going to maximize the use of the joint? That's all that you should focus. Okay. And you should also avoid weight bearing on inflamed joint. I told you that most of the times it can affect every joint, okay? But most of the times it affects the joint on the hand and the feet. Okay, so what do? Seeing this like an contracture stiffness and if patient want to lift something, you see pain will become worse. All right, so we shouldn't bear weight where there's what? Enough pain, where there's inflamed pain, joint. Okay, so teach proper body alignment as well. Supposing the vertebra, the hip joint, the knee, they are all affected. So body alignment. That's why I told you that we need to splint the joints. Okay, especially in what? Flare-ups. So splinting, that is helping the joint to be in its anatomical position. That's all that we have to do. Okay, so during rest, why? Because when we are sleeping, that's when we are resting. And especially if care is not taken, during the morning hours, patient can't turn because patient wasn't in what? Proper body alignment. Okay, so we have to teach the patient how to do what? Proper body alignment. Okay, during rest periods with firm mattress. So we need firm mattress, not any other mattress. Firm, because if not firm, you sink into the bed, and you don't want that to happen. Encourage your position of what? Extension, because you want to avoid what? Flexion, what? Contractures. So always help the patient to extend. Extension is very, very important, not flexion. Extension. So we encourage position of extension and avoid flexion. You modify home. Patient is being disturbed. What will be your home teachings? Okay, environment where the patient is working. What will be your teaching to this patient? Okay, so when patient is going to the house, what do we have to tell the patient? You need to press water from sponge instead of wringing. So when after bath or maybe you wash, okay, you have to press the water from what? The sponge. Press it. Don't squeeze it. You see, after washing, what do? We squeeze to remove the water, right? From the cloth or sometimes from the sponge. You don't have to squeeze it, because if you squeeze, you are trying to twist the joint. And we don't want to apply pressure on where? Inflamed joint. If we want to bear weight, the weight should be at where? Where we have strong joints. Because the wrist is inflamed. So if you press it, you are trying to prevent twisting of the joint. It's like pressing something down. It's like when patient is in certain position, patient want to rise up. Okay, what do? You press the handle, okay, with the palms, not with the fingers. So place the palms on the arms of the chair. Okay, not the fingers, because if you place the fingers on the armrest, okay, that one you are placing or you are putting much pressure on the joint, smaller joints. It's not going to help the patient. Are you please okay? So these are your home tips that you have to give to the patient. Okay, you press water from sponge instead of wrangling. Don't squeeze. That's what I mean. Don't squeeze the sponge. If not, you are applying you are bearing weight on the smaller joints. You bear weight on the stronger joints, on the bigger joints, not the smaller joints. So don't squeeze, don't wrangle the sponge. You have to press. That's what you have to tell the patient. Flat pillows under the head, as I told you, or the shoulders, but not under the knees. You want to prevent flexion contractures. Push with palms. When you are pushing, you are in a certain position, you want to rise up. You use the palms, okay, not the fingers. Mind you, avoid repetitious movement. Okay, so anything like when you are typing, or those who sew, okay, sewing. So that's one is what? Repetitive what? Work. So tell the patient to avoid such work. Do you please understand? All right. And I told you it's a systemic condition. So we have to avoid all fatigue. So as I told you, we do work, rest, work, rest. Okay. So we pace activity. Pacing activity is very, very important. Okay. And slide object instead of lifting. So if there's an object, if let's say there's a doorknob, okay, you have to get a doorknob that you cannot push, not to twist. Okay, if you want to, there's an object, instead of you lifting, you have to what? Rather push. When you push, you are trying to exert pressure on all the joints instead of smaller joints. Do you understand, please? Are you please okay?
Yes, sir.
Please come again with the pushing.
What I'm saying is that if there's something on the floor, instead of you lifting, because when you lift with your hand, okay, sometimes you lift with the fingers. And it's going to affect because you're having inflammation on the fingers. So instead of you pushing, instead of you lifting, you have to push or slide. Do you understand? Because if you push,
Yes.
what are you doing? You are trying to exert pressure on the wrist, on the elbows, and even the shoulders, isn't it? When you push, when you're pushing something, the pressure will be exerted on the wrist, on the elbows, and on the shoulders. But if you lift, you are trying to put pressure. The pressure will be more on the fingers. Okay, so instead of you lifting something, try to push. So these are your home teachings. If you have a doorknob, instead of you twisting the doorknob to open the door, it should be something that you can push or you can slide. I hope it makes sense.
Yeah,
Sit
I get
on
it. Thank you.
instead of what? Standing during meal preparation. So I told you, you have to conserve energy. Because patient becomes fatigued because of systemic manifestation. Anemia can even happen. Okay, so what do? Instead of you standing, whilst you are preparing food, you are trying to do some sort of activity. But at the same time, you have to conserve energy, not to stop cooking. Rather, you have to sit. So once you sit and you do prepare your food, you are conserving energy. So you have to avoid prolonged standing. Why? Even prolonged sitting, prolonged squatting. Why? Because prolonged sitting can cause what? Contractures, isn't it? Stiffness. So as I told you, your focus is avoiding stiffness, reducing pain, avoiding contractures. So what are we to do? As simple as that. So once you understand what you are to do, if the question is asked, what am I to do to prevent contractures? What am I to do to prevent stiffness? Is this activity going to cause stiffness or going to cause contractures or pain, especially during flare-ups? How do you prevent contractures? You have to strengthen. So these things you have to take note. Okay. Standing, prolonged standing. What happens? Stiffness, prolonged sitting. I told you even that when you sleep overnight, in the morning, stiffness, contractures. Unless you put the body into activity, there you see that the pain is going down. And even because we lie down for a long time, stiffness will take a longer time in rheumatoid because it's a flow before the pain goes or the stiffness is relieved. Okay, so that's what you have to do. And because of disturbed body image, help the patient to verbalize feeling. All right. So that's what you have to know. What are some of the management? Synovectomy. You have to remove the whole synovial membrane. Okay, including the joint. All right. And sometimes you have to do replacement of the joint. That is what? Arthroplasty. And I hope remember arthroplasty. Our teachings on arthroplasty. Do you remember? Hello. Do you remember our teaching on arthroplasty about your positioning, preventing contractures? I hope you remember. Any question? All right. So we have to do arthroplasty. Okay. We have to replace the joint. If it's about the knee, replace the knee. So after knee replacement, which is arthroplasty, what will be your teaching? Okay. This is what you should consider. Okay. So who can help me? Let's mention them, few of them. Yes.
So what's your question?
Can
please,
can
what's the
can
question?
we can we tell them to avoid crossing the legs?
Yes. So avoid crossing the legs. Okay. Because mind you, when you cross the leg, what is going to happen? Either what?
It will impede blood flow.
Posterior dislocation or what? Anterior dislocation. So we have to avoid dislocation. So that's by avoiding crossing the leg. Okay. Any other? Yes.
Do not bend to pull your socks, something like that.
Okay. See, when you bend, okay, this one can also have effects. All right. So bending below at the waist, okay, it's also very important, especially if we do hip replacement. Okay. And mind you, we have to use with all these things, we have to use what we call assistive devices in walking, because walking becomes very painful So help the patient to use what? Assistive devices. Help the patient to use crutches. So if it's about activity that patient has to do, at least you should cluster the activity. Do you understand? So help the patient, tell the patient, don't twist your body anyhow. Okay, very, very important. All right. And when you are lifting or transferring, you are doing something, use proper technique. Tell the patient. All right. So these are the things that you have to focus when it comes to this. Are you okay, please?
Yes, boss.
All right. So what are some of the complications? Mind you, with this one, let me show you something before you come to this so that you appreciate it. So all right. I've seen this. When you open your hand on your palm, I hope you can see a dip or a hole. Can you see that in your hand? Middle of the hand. Can you see like a dip?
Yes.
Yes.
So when you trace the dip to the carpal is what? The wrist bone. Okay. When you trace the dip, that is this place. That's what I'm talking about. You can see that when you open your hand, there's a small dip here. When you trace it to the wrist, that's the carpal bone. Okay. That's where we have the nerve. The nerve. Okay. And we have tendons as well. Okay. And we have the median nerve, the middle. Okay, median nerve running through there. So supposing that there's rheumatoid arthritis, we have muscles, we have nerves, we have ligaments, and then the nerve, the median nerve, is just running medially through the carpal to supply the hands. So if there's inflammation over here, if there's anything like inflammation constricting the nerve, what will happen? Loss of sensation. You understand? So if this one is the tunnel, the carpal tunnel, that's the hole through which the ligament and the bones and the whatever passes through. That's a tunnel. So carpal tunnel syndrome means that all these ligament and the tendon and the whatever is compressing on what? The median nerve. And once it happens like that, that's what we call carpal tunnel syndrome. You understand? Are you okay? So once it happens like that, it's like when you are doing disc herniation, and once it affects the nerve that supplies the hand, you are going to have what? radiculopathy. I'll remember radius, radiculopathy on the hand. So pain, okay, numbness, sensation because it's affecting the nerve. The same thing applies here. So it means that holding something becomes a bit difficult, lifting becomes difficult, using the hand to ride, to button the shirt, as we saw in radiculopathy in this herniation, the same thing is happening here. I hope I'm not confusing you.
No, no.
All right.
Remember.
So that is the same thing. So once there's rheumatoid arthritis, supposing it's affecting the wrist joint, okay, together with inflammation of the vessels, what is going to happen is going to cause constriction of the median nerve. All right. So compression of the median nerve, which enters the hand at the wrist through that tunnel. That's what we call the carpal tunnel. Okay. So that carpal tunnel is very narrow. That's where the median nerve enters to supply the hand. So if there's compression of this median nerve, that is what we call carpal tunnel syndrome. And it can happen in rheumatoid arthritis. Okay. It can happen in what? Diabetes. You know, diabetes, we're looking at nerve. If it affects the nerves. Pregnancy, if there's, because of what? Hormone. And even menopause. And even premenstrual. Because of hormonal involvement. Okay. And peripheral vascular disease. When is the vessel? Once the vessel supplying the peripheries, okay, is occluded, okay, the nerves wouldn't get enough blood supply. And it causes this. So all these are risk factors to get what? Carpal tunnel syndrome. And one of the complications of rheumatoid arthritis is carpal tunnel syndrome. So what are we going to see? Like radiculopathy, this herniation causing radiculopathy, this thing, the same thing, impaired sensation, because nerves have to do with senses, sensory, and motor function. They're all impaired. Okay, so pain, numbness, tingling, sensation. And this one, because of this, sometimes if you sleep, the pain and then tingling and the numbness is going to wake you up at night. Even sometimes, normally when you are sleeping, someone will just wake up and say, I slept on my hand. So because sleeping, you didn't know the kind of position you are in. That's why it's important to tell patients with rheumatoid arthritis to assume what? Proper body alignment when sleeping. Because, mind you, you are coming to meet morning stiffness upon awakening. So this thing also will cause numbness, tingling sensation, and this one will awaken you during the night hours. Weakness on that hand, as you saw, radiculopathy. Clumsiness, the same thing happened in radiculopathy. Means you are holding some objects and it falls. Because there's lack of sensation, weakness as well. Okay, struggling with button. You can't button your shirt. Okay, writing difficulty, muscle atrophy. I told you that once the nerve is not working, once the bone is not working, it affects the muscle. Because you wouldn't use the muscle to work as well. And this one will cause atrophy. As you saw in this herniation, it can cause muscle atrophy. The same thing here. All right, in carpal tunnel syndrome. So mind you, what would be the management when you have carpal tunnel syndrome? Rest. Rest. Okay. Rest immobilization. Look at where the wrist is, and look at where the median nerve. And when we are walking, we always move the hand. Okay, so we have to immobilize the hand with the help of what? Splints. So during the night, just splint the wrist. Okay, to avoid unintentional movement. Okay, and if you do so, pain will go down. All right, and also to help the joint to be in a neutral position, and stop any activity that will cause movement, especially during the early symptoms. When it's occurring, it happens in the early symptoms. Any activity that will aggravate the situation or aggravate the movement of the hand, you have to stop. Because that time, pain is so severe. So that time, rest is important. As is also important in this herniation causing radiculopathy. As is important in rheumatoid arthritis, where we have to balance rest with what? Activity. All right. But mind you, during flare-ups where the pain is so severe, you have to do rest. In rheumatoid arthritis, during exacerbation, you have to what? Rest. When the pain resolves or goes down, that's where we need to what? Do put the hand into what? Activity. All right. And hand and wrist exercise. So we need to exercise the hand as well. Okay. So with all these things, there's no way we have to do straight bed rest or total bed rest. No. You all need to be exercised. Okay. But we also have to do corticosteroid. Okay, corticosteroid injection. And this one, we inject the corticosteroid into the carpal canal. Because I told you that if there is inflammation, if there is edema, and especially in pregnant women, if there's even I told you that it's hormonal involvement. And apart from that, they get edema. Pregnancy, there's edema. So if there's edema around the wrist and it's compressing on the carpal, the median vein, the median nerve, okay, it's going to result in this. So what do? We have to inject corticosteroid. An example is what? Corticosteroid. Yes. Corticosteroid. Example.
Hydrocort.
Okay. Very good. And what? Solomidrol. I hope you know solomidrol.
Prednisone.
Methylprednisolone. Very good. So Dexa. All right. So all these things we inject into the carpal canal. Okay, just to reduce inflammation. Once inflammation reduces, compression goes away. Okay. I hope this thing is like similarly looks like a compartment syndrome. Okay. So that one is also compartment syndrome. And this one carpal tunnel syndrome. Because we don't have only one cause. Okay. So that's what is happening. And with rheumatoid arthritis, so one complication, as we've seen, is what? Carpal tunnel syndrome, whereby there's compression, whereby there's vasculitis, okay, inflammation of the vessels, compressing the median nerve, supplying the hand. Okay. And I told you that it can affect rheumatoid arthritis flow, to affect every part of the body where blood flows. Okay. So when we have rheumatoid arthritis and patient is exhibiting neurological symptoms, what do? Or what should come into mind? It means that either there's what? Nerve compression or cervical spine compression. Because as you saw, the bone, inflammation, panels formation, damage to the joints, okay, bone erosion, deformity, all these things, if there's a nerve running through the spinal, the spine, okay, it can compress that. All right. So if it's about maybe the injury is around the neck, meaning that we are going to have cervical or spine compression. Okay. If we are having patient is developing eye pain and patient has history of rheumatoid arthritis, and suddenly there's eye pain, there's redness, okay, there's cataracts, there's vision disturbances. What comes into mind? There's inflammation. All right. The blood vessel supplying that eye is having a problem. So that's for rheumatoid arthritis. Any question? Okay. Sometimes we can compare osteoarthritis with rheumatoid arthritis in a case study. Yes, Sister Jane.
But Frank, it looks like it can happen in pregnancy. So my concern is about the methotrexate use in pregnancy. Is it allowed? Because I know that when you inject methotrexate, it's sort of an anti-cancer drug that has the tendency to detach the baby from the uterus.
Okay, very good. Who can help with this, please? Yes. Sister
Please,
Abigail,
what was the question?
his question is her question is with pregnancy. He said this one can occur in pregnancy. So if one is pregnant, and one of the medication that we give is methotrexate to cause immune suppression. So what are you going to do? Yes.
But Frank,
Yes, please.
please, I was concerned about methotrexate use in pregnancy.
Yes.
Okay.
Yes. So we understand your question. So I'm saying anyone who can help us.
In this
Yeah,
case, then we use a different alternative.
Okay.
So, like the etanercept that we've mentioned, if that one is not teratogenic, it means that we can go for that one.
All right. Any other?
I think in this case, we can add a folic acid, as you said.
Folic acid.
It will not make it work. Oh.
This one, we are going to cause abortion altogether. Do you understand? Because methotrexate is going to cause fetal degeneration, going to cause death of the fetus. Because the cells will not be divided. Mitosis is going to halt. When you give methotrexate, that's what happens. That's why you give methotrexate in what? Ectopic pregnancy. Because we know where the pregnancy is. If it grows, there's going to it's going to lead to what? Rupture. Okay, so we give methotrexate to suppress it. So you can't give methotrexate to a pregnant woman. No, obviously we are going to cause damage. Yes, please, Step Abigail. Yes, Sister Abigail. Okay. So obviously, as our brother said, we are going to have another alternative. Okay. So etanercept can be given or any other drug that's deemed spread. Okay. But we can't give folic acid together. No. You can't do that in pregnancy. Sister Abigail said you are unable to mute. There's a mic arrow, mic sign, okay, that you can see. So just press on it and okay. All right. So we are looking at osteoarthritis. So if flow rheumatoid is symmetrical, what do you think would be osteoarthritis? It will be what?
Asymmetric.
Asymmetrical. So once we understand that flow, we are looking at the whole system, which is symmetrical, and flow, because of flow, when you sleep, flow takes a very long time to reach the body. So it takes a long time. So if it takes more than 30 minutes in rheumatoid arthritis for stiffness to go down, what do you think will happen to the osteoarthritis? Stiffness time will be shorter or longer? Shorter or longer? Shorter. Okay, so just understand the concept. Just know the flow with rule and you'll be able to distinguish between the two. So with this one, as we saw with rheumatoid, is the whole thing is what? Activation of the rheumatoid factor, which is an autoimmune. But osteoarthritis is not an autoimmune. So osteo, we are looking at the bone. So this one is not a systemic. Okay, so because flow, we are looking at flow. It's not every part where we have bone. So osteoarthritis can be systemic. So we won't see any systemic manifestation. But flow, every part of the body, there's flow. So that one is systemic. And know that the rheumatoid is an autoimmune condition. Osteoarthritis is not an autoimmune, but it's rather degenerative. And this one is non-inflammatory. Mind you, I told you that with osteoarthritis, rheumatoid arthritis is what? Inflammatory. Okay. Sister Edith is saying that I wanted to add that I had carpal tunnel in both pregnancies. Okay, so she's sharing her experience that she had carpal tunnel in both pregnancies, and I was told I couldn't have any treatment but to just manage with splints, and it resolved on its own after pregnancy. All right, thank you. So as sister is saying, this one is carpal tunnel syndrome. Okay, but we are rather looking at rheumatoid arthritis. Okay, in its management with methotrexate, isn't it? But for carpal tunnel syndrome, it's just constriction. So this one, once the hormone results or hormonal levels go down, or inflammation goes down, it's like the what was the name? Compartment syndrome. Once the cause goes down, this one is going to resolve. Okay. So thank you for sharing your experience. That's it. With carpal tunnel, no medication in pregnancy, it can go down. Okay. Just have to manage with the splints. That's very, very important. Okay, especially during the night. All right. To avoid movement, but you have to do exercise. Not to. It just doesn't mean that you have to avoid exercising. No. Okay. We do exercise and at the same time, what's the name? Rest. Okay. But during the night, that's where it's very, very important to apply the splints, okay, in carpal tunnel syndrome, all right, to prevent unintentional movement during the night because you don't know where you move, okay, all right. So with osteoarthritis, this one is degenerative condition. It's not an inflammatory condition. Although you can see sometimes just small inflammation, but it's not an inflammatory condition. Okay. So this one causes cartilage breakdown. The cartilage is just the wax, okay, that's pushes the joint. Okay, that surrounds the joint, the two joints. All right. Yeah, Sister Precious.
Yes, but Frank, if you say it's not an inflammatory condition, so why do we have the itis in it?
Why do you have the itis?
Yes.
Okay. It's very simple. With osteoarthritis, unlike the what's the name? Rheumatoid arthritis, where you have an inflammation, systemic inflammation. Okay. With this one, I said is non-inflammatory because the condition itself is not causing the inflammation. If there's going to be an inflammation, it would be a secondary inflammation, like maybe white blood cells coming there to cause a small inflammation. And even if there's going to be inflammation, just something small. Okay. And apart from that, it can be as a result of the cartilages breaking down. Okay. But unlike rheumatoid arthritis, where it causes vascularitis, that's systemic inflammation and systemic manifestation, this one is not like that. You understand?
Okay. Thank you.
Okay. So don't worry, we're going to see it with the manifestation will tell us, okay, how this one can be distinguished from rheumatoid arthritis. And mostly it affects the knees. The joint hands affects the weight-bearing joint. Mind you, these affect the weight-bearing. Our hip, where we put much weight. Knees, when you are walking, okay, much weight, we bear much weight on the knees, okay, and the hands as well. All right, so that is what you should know. And easily affect joints on what? One side of the body. I told you this one is asymmetrical. One side. So if you see that we're having inflammation, okay, we're having inflammation on both sides. What is it? What will come to mind?
Rheumatoid arthritis.
Rheumatoid arthritis. But that one is flowing everywhere. Okay. Yes. So there's no systemic manifestation and risk factors aging. So it means that this one affects the aging. And all these things they affect our ladies as well. Our ladies, this one is your own disease condition, okay? It affects, most of them affects our ladies. So this one aging, as I told you, rheumatoid flow, there's flow in every body. Okay, so this one, rheumatoid can affect both the aged and the young. All right. But with this one, it affects mostly the aged. So decreasing estrogen at menopause. That's why it affects our ladies much more than the men. Okay. Obesity. All right. Because that one you're putting, because aging, you know that with aging, we are looking at the cartilages. Okay. And the joint movement becomes problem. There's joint stiffness and those stuff associated with aging, which compound to this condition. All right. So, and obesity, you know, with obesity, you are putting much pressure on the weight-bearing joints. Okay. And trauma. Smoking too can cause cartilage deformity or joint deformity. And drugs like corticosteroid and even cortisone can cause that. Okay, so that's what you should know. So drugs can cause, corticosteroid is, we all know that it's one of the commonest causes of infection, commonest causes of joint deformity, okay, fractures and those stuff. All right. So what are the manifestations? Joint pain and stiffness primarily affect the hips. That is the weight bearing. So once you get to know what's name? Osteoarthritis, we are looking at the weight bearing joint. So it means that this one, together with rheumatoid arthritis, will have similar management, especially when it comes to exercise. All right. When it comes to maintaining body alignment or anatomical positions, when it comes to doing exercise, so we see the management. All right. So with this one, it affects the hips, the joints, the hip joints, the knees, and the hands. Stiffness occurs after a period of rest. Okay. Mind you, joint stiffness in rheumatoid arthritis, we said it occurs when there's what? Prolonged rest, isn't it? After sleeping. Flow. Well, body blood flows to every part of the body. When you sleep and the body is relaxed, after waking up, that's where you see stiffness. The same thing happens here. So that's why we have morning stiffness in both rheumatoid arthritis and osteoarthritis. But the timing differs. Okay, so we have early morning stiffness in both, but the timing differs. We know flow takes very long time as compared to what? The osteoarthritis. And with this one, pain becomes worse with activity. Okay, better with rest. When we are doing rheumatoid arthritis, when does pain become worse? Is it rest or activity?
Rest.
Right.
Pain becomes worse in rest, right? With rest. But it becomes resolved or they decrease with what? Normal activity, isn't it?
Yes.
Normal activity. But what if you movement, or excessive movement or exercise will increase the pain. Okay, that's why when there's no flare-ups, you have to manage rest with exercise. But with this one, once you are moving, okay, pain becomes worse. But you rest, pain is relieved. But with the flow, because the blood flows to every part, and we know that if you take your rest, everybody, if you sleep overnight, in the morning, become very tired. Okay, it means that there's flow in everybody. So with rheumatoid arthritis, resting will worsen the pain. But osteoarthritis, because with the age, becomes worse with rest. May have pain at rest when we reach the advanced stage of the condition. Okay, and symptoms are aggravated by what? Temperature change or climate change. All right, so that's what you have to do. So once there's temperature change, okay, symptoms will be aggravated. And decreased joint mobility, you can't be able to, you just can't exercise the joint. All right, so there's decreased joint mobility, and morning stiffness lasts less than 30 minutes. It's not a flow, so the time takes short. Okay. Crepitations or crepitus That's the grating sensation once the bone moves or slides against each other. Okay, once the bone is moving, because the cartilage, the articular cartilage that covers the surface of the bone, okay, where the two joints meet. As you saw, the two joints meet, okay, at the point of meeting, each has a cartilage. I hope you've taken, you've been chewing bones of a cow before, right? You can see that not even a cow, even any other bone, okay, you can see that at the joint, there's something white in color that sometimes becomes so much attached to the joint that you find it difficult to detach and chew. Have you seen that one?
Yes.
I hope you've seen that one before. That is the cartilage that we are looking at. Okay. So if we are having problem with cartilage, and this one is degeneration, degenerative non-inflammatory condition, it means that once the joint, that the cartilages that cover the bone, okay, is degenerated. What happens? The joint, the ends of the joint will come directly in connection with each joint. So what is going to happen? There's going to be grating sensation. Once you move, you can see that the joints are grinding against each other because the cartilage, which helps to cushion, to prevent friction, is no more. So crepitation, that sound that we hear, is what we call crepitation. Okay, that is it. So minimal joint swelling, because I told you there's what is non-inflammatory. So the joint is the swelling is minimal, unlike rheumatoid, which has to do with the flow of blood. So swelling is much. But with this one, there's minimal joint swelling. Difficulty getting up after prolonged sitting. The same thing with rheumatoid, because when you lie down for a long time, getting up becomes difficult. That's why we have stiffness after prolonged sitting or standing or whatever. But just that, the time that it takes to go away different. Okay. And skeletal muscle disuse. That's atrophy, muscle atrophy. Because we are not using the joint, we are going to see the muscle decreasing in size and strength. Compression of the spine causes radiating pain. Okay, the spine. Once the spine, if it's about the lumbar or the sacral or the cervical, if we are having the cartilages, they are no longer there, what will happen? If there's a spine, if there's a nerve, they start compression on the nerve. They start compressing on the nerve and cause pain that radiates to the area where the nerve is supplying. Stiffness and muscle spasms, so no organ involvement because it's not a systemic inflammation. And we have what we call, let's look at the manifestation and clues. We have what we call Heberden's node and what? Bouchard nodes. Heberden's nose and Bouchard nose. Mind you, in rheumatoid arthritis, we have swan neck and what? Swan neck and what?
Yes.
Botanier what? Deformity. You have those deformities, swan neck deformity and botanier deformity. In osteo, we have the Heberden's nodes and the Bouchard nodes. This one, mind you, unlike rheumatoid arthritis, where we have that spongy feeling, very soft. Okay, with rheumatoid, with osteoarthritis, the swelling that we get at the joint. So know that with osteoarthritis, we get swelling at the joint. Okay, and that swelling is not an inflammation. It's the bone. It is the bone. But when you go to the rheumatoid arthritis, the swelling that you see is what we call rheumatoid nodules. And that one is firm, but it's not bony. This one has to do with bone, the osteo, that's doing bone. Because it's not an inflammation which involves the fluid. It's about the bone itself. So we have what we call the Hebden's nodes and the Bouchard nodes. The Hebden's, get the differences. The Hebden's, they all had bony swelling, but the area differs. Hebden's means very high, means that we are looking at the distance part. Okay, like what we are looking at when we are looking at the swan neck and then the bush what's the name? Let me show you how it looks like so that you know. Okay. All right. Okay. Are you here? You see the Hebden's nodes. You can see there's a node here that's hard, firm, bony. Okay, it's not soft as in rheumatoid. Because rheumatoid has to do with the blood flow, so that one's soft. But with osteoarthritis, it's hard, bone. Your osteo, bone. Osteo means bone. So the Hebden's nodes, we're looking at high, very far. Okay, that is the distal phalanges. And the Bouchard nose, we're looking at that one below it. And that is the what? The medial. Are you please okay? Do you understand, please?
Yes, we do.
Okay. So let's finish with this. And so the Hebden's nose, distal interphalangeal joint, distal, the very far joint, that's the Hebden's nose. And when you come before that distal, that is what we call the Bouchard nose. That's the proximal. Okay, the distal is Hebden, very high, Hebden, and the Bouchard node is the before. That is the proximal joint. So we are ending here with the manifestation. Any question? Any question? I hope you can differentiate between osteoarthritis and rheumatoid arthritis, right?
Yes.
The differentiation is not difficult, right?
Yeah.
One you do that is a flow to every part, systemic, bilateral, or symmetrical. Okay, inflammation going, systemic manifestation. Okay, flow is in everybody, so the young and then adult. So mostly the young is affected. When you go to osteo, it's unilateral. Okay, the joints, all right, those weight-bearing joints, okay, with non-inflammatory, but the swelling there is bony. It's bony, unlike the spongy, soft noodles that we see in rheumatoid arthritis. But osteo bone, you're looking at bony, bony formation, lumps. Okay, in this bony formation that we have, we call it either hebendens. That's high, that is the distal. Okay, and then what? The Bouchard nodes, and that is what? The proximal interphalangeal joint. And when you go to the rheumatoid, we have that deformity. That's where we have the what? The botanier deformity and then the swan neck deformity. It's not difficult to distinguish. Just understand it and you're good to go. All right. If there's no question, then we want to end here. All right.
Boss Frank.
Yes, please.
Boss Frank. Yes, please. So I want to be a bit clear with the resting in the rheumatoid arthritis. Is it when the pain is at the bit that we encourage resting? I want to be sure about that point, please.
Rheumatoid arthritis.
Yes, please.
Once there's severe pain, once there's flare-ups, as a patient, we need to what? Rest. Because little pain, a little movement, okay?
Okay.
Mind you, is normal activity that will reduce, but movement, excessive movement, stress will increase the pain, and prolonged resting too will increase the pain. Okay, prolonged resting, bed rest, because once you sleep, the body is relaxed, flow decreases, and once you wake up, stiffness, pain. So with rheumatoid, prolonged resting will rather increase what? The pain.
Okay.
And even more movement will also cause pain. But with the normal, that's why after prolonged rest, how do we avoid pain? We try to move the hands slowly, okay? Slowly, the normal activity till the pain will resolves. If you want to move like walking and moving, shaking your hand anyhow, pain is going to occur. When you come to, so once there's pain, flare-ups, what do? You have to immobilize, rest, split it. Okay, if there's no pain, normal manifestation, because this one is irreversible, permanent. So if there's no pain, what do? You have to be balanced. We have to balance what? Pain with what? Rest. Like normal activity, because it's a flow to everybody, every part of it. So you have to exercise, you have to rest like that. You have to conserve energy, you have to split if there is severe pain, flare-ups. When we come to osteoarthritis, this one, we are looking at joint itself, the cartilage, which has been degenerated. Okay, the size going down, that degeneration. And eventually it will expose the surfaces of the bone, grating against each other. That is the crepitus. So you see crepitation in osteoarthritis, but not in flow. But flow, there's inflammation on bone. You see crepitation in bone, where the cartilages are worn off, the joint coming together. So if there's pain, and pain happens when there is what? When you rest. But mind you, prolonged resting in any of them will lead to stiffness. That's why we have morning stiffness in both. If it's like normal activity, if you're not putting the joint into activity, what happens? Stiffness. So in all of them, we have stiffness, whether you like it or not. Prolonged rest will result in stiffness in any of them. But we are saying that with joints, because the joints are coming in contact with each other, okay, what happens? If you move, the joints are creating against each other. So that one, pain comes. If you rest more, then the bones are not grating against each other. So pain what? Goes down. Do you understand? So it means that in osteoarthritis, because the pain and the joints are not grating against each other, in osteoarthritis, because the joints are grating against each other, that's crepitation. If you take rest, then because we are not going to have any crepitation, the joint the pain goes down. Once you start moving and crepitation comes, pain comes in osteoarthritis. Do you understand the differences, please? So
yes, please. It's better now.
Rest helps with what? Osteoarthritis.
Yes. Thank you.
But Frank, please,
Yes,
do you have pain in both of them when there's a prolonged rest?
when there's prolonged rest, obviously you're going to have pain. Because it's about the two of them, they are about joints. Okay, the two of them affect joints. And once you are not exercising, prolonged rest will definitely result in pain. But once you are maybe during the daytime, you start moving. With osteoarthritis, because the pain are coming in direct contact with each other because of cartilage degeneration and creating crepitations. What happened? You feel the pain because that cartilage is there to prevent friction. So if you start moving and then the joints are creating against each other, then pain. So what do? You have to take rest and then pain goes away in osteoarthritis. So both of them, prolonged rest will lead to pain. But just that with rheumatoid arthritis, after the prolonged rest, if you try to do normal activity, the pain goes down, but not in osteo. I hope you understand, because osteo, when you are doing activity, the bone surfaces will be grating against each other. So you don't want to cause the pain. So you have to rest. So that's how it is.
Okay, thank you.
All right. Okay, if there's no question, I wish you well. Just try to learn, understand the two mechanisms, okay, or the physiology, and you will be able to understand how. So the main point is, how do I prevent deformity? How do I prevent contractures? How do I stabilize the joint in anatomical position? What type of exercise is allowed to prevent pain? So once you know this, that's all about joint deformities, musculoskeletal problems, all has to do with these things that you're talking about. All right? Okay.